Good morning, everyone. Can you hear me?
Yes, we can hear you.
Yeah.
So today we've got a talk from Dr. Ahmed. He's telling us about contemporary management and outcomes in congenitally correct transposition of the great arteries. It's a journal club, and we swapped the sessions as we had some technical issues. So today, Ahmed kindly presenting the journal club regarding the same topics that we started last week with beautiful presentation of Bernie. So Ahmed, please, you can start.
Hello?
Yeah, we can hear you.
Hello? Am I heard now?
Yeah, Ahmed, is it you?
Yes, it is me.
Yeah, you can start, please.
Okay, so so Sherry is sharing this one, and so I'm just gonna go through mine and from here, and we can go. So good morning all, and thanks for staying with us during this glitch in the start. So I haven't been sharing on Microsoft Teams the presentations before, so that's why we are taking this time. And sorry for also the presentation might be a little bit not refined because it was a last minute request from Oleg. So today we're going to talk briefly on a review that I have found on regarding the congenitally corrected TGA, and it talks in general about the contemporary management and outcomes in congenital corrected transposition of the great arteries. This has been published in July 2018 in Hearts. We'll go. I've just did a simplification of it rather than anything. And I know that you had an extensive and detailed talk last week by Bernie about the physiology, embryology, and anatomy of the congenitally corrected TGA. So let's start. So the introduction, we all know that the congenitally corrected TGA is mainly an abnormal leftward looping of the primitive heart, leading to two main things: the morphologically left ventricle being positioned to the right of the morphologically right ventricle, with both AV and VA discordance. That's the next, the previous page to that. The next one will be the scheme of the presentation of the congenitally corrected transposition of the great arteries. So we can see on the first one, which is the normal heart, and then we can see on both the lower ones the corrected the one number B is the congenitally corrected TGA, C and D are the surgically corrected part. Next slide is going to be the associated lesions. As we have discussed earlier in the previous meeting, it's commonly associated with valve abnormalities and septal defects. So there is VSDs, PS, subpulmonary stenosis as a result of malalignment of the atrial and the inlet part of the ventricular septum. That malalignment has implications for the VSD side. It also affects the severity of the left ventricular outflow obstruction and the position of the conduction tissues. All these main three points will have an implication on the way that we are going to do and the surgical techniques. The tricuspid valve are commonly affected. It can be an isolated congenitally corrected TGA, but this is not very common, and it usually comes with something else. So it can be with a single ventricle. That's the next page, sorry. It can be with the mitral tricuspid atresia, dextrocardia, anomalous systemic and pulmonary venous connections. And the coronary arteries are usually a mirror image distribution to the normal anatomy. The conduction tissue also lies abnormally, so it's more situated anteriorly, and it's more prone to progressive dysfunction. The next will be the schematic presentation of the mirror image of the coronary artery. The A is the normal distribution, and the congenitally corrected TGA is on the left side. So the because of the left side is the morphologically right ventricle, the left coronary is coming on the right side and the left side, and on the other side, which is the morphological left ventricle, we have the coronary arteries coming out from the other side. Isolated congenitally connected transposition of great arteries is variable and depends primarily on three points, which is the function of the RV, functions of the tricuspid valve, and development of arrhythmias. And it also relates to a sequence of abnormal RV loading, then a tricuspid regurgitation leads to a decompensation of the heart and a congestive heart failure. There was a study about that this, by the age of 45, about 2/3 of the patients with the congenitally corrected TGA would be presenting with an element of congestive heart failure. The congenital corrected TGA, when it comes with VSD or PS, the VSD itself promotes the reversible and then the irreversible pulmonary vascular disease because of the increased blood flow to the pulmonary arteries as normal, as in any normal VSD. Pulmonary or subpulmonary can also protect against the injury of the pulmonary arteries, so might be a little bit beneficial from the surgical point of view. Surgical options for management of the congenitally corrected TGA are actually either physiological or anatomical correction. So the physiological correction, there's no rerouting of the bloods, so we only address the associated lesions if there is a VSD or tricuspid valve repair, for example. While in the anatomically corrective approach, we want to establish the connection between the LV and the aorta and the systemic part and the right ventricle, the morphological right ventricle, and the pulmonary circulation. So redirection of the flow within the atrial portion usually goes on with either a mastered Senning baffle, the arterial switch procedure or a Rastelli to redirect the systemic blood flow. Usually this is also accompanied by repair of the VSD, surgical relief of the left ventricular outflow tract obstruction in according to each case. Usually the timing is of this surgery is as early as possible. However, when we have a VSD or a PS, the pressure loading in the left ventricle to systemic levels, double switch operation can be deferred beyond the neonatal time without the LV deconditioning problems that could affect negatively the surgical outcome. So as a conclusion of that, the double switch is a realistic option if the LV is capable of generating pressure required to overcome the overload of the systemic arterial circulation. Next. The uncomplicated ccTGA LV will decondition quickly after birth and will require a preparation by pulmonary artery banding sometimes. Long-term follow-up confirms that the physiological repair, leaving the RV as a systemic ventricle, has a suboptimal survival and a limited freedom of reoperation. The tricuspid valve replacement, electrical synchronization, and ventricular assisted device are another option for the management of the heart failure. And this falls on more or less like the physiological part of the repair rather than the anatomical repair. Ultimately, cardiac transplantation, if the pharmacological and the surgical palliative measures for the heart failure are not useful and not successful, so they may be the only option for this cohort of patients to have a transplant to prolong their life. Mentioning that, there was some points about the surgical LV preparation, and it's most successful in infants and very young children, but it's commonly not commonly undertaken in adolescents and adults, because when this is being done in this group of patients, they have noticed that the ventricle responds by hypertrophy rather than hyperplasia, so it's not doesn't improve the outcome after that. So the early training of the left ventricle is more beneficial than late one. Next. So there are some pitfalls with the and side effects with the surgical outcome. So there is an LV failure, and there was a study that also showed that it's the main factors that could affect the left ventricular function post-surgery is the age at the repair. So the older than 10 years, the results are not better. If weight is more than 20 kilograms, if a pacemaker was required, or if there was a severe neo-aortic regurgitation. Also, there are other shortcomings of the Senning or the master, which is the channel obstruction. There is a leak, arrhythmias, which is mainly sick sinus syndrome and other atrial tachyarrhythmias. Next is going to be the Rastelli itself. It's the other option of treating the congenitally corrected TGA, especially when we have got a PS or a alveolar or subvalvular. So it's a challenging procedure because the VSD patch itself can produce subaortic stenosis. And also the prosthetic connection, when you use an RVPA conduit from the right ventricle, it's going to ultimately deteriorate. I have looked and I found that there was the next page. There was one meta-analysis to look into the different types of anatomic repair, which is they compared both the anatomical repair types which are used for the ccTGA, either as a Rastelli and atrial switch, or an atrial switch compared to combined with arterial switch. This is a little bit old one, about 14 years ago, and they looked mainly into the surgical approach. Is any one of them superior to the other in reducing the incidence of in-hospital mortality in the patients with congenitally corrected TGA? So they included 11 studies that involved 124 patients. That's in the next page. The results of this study suggest. The results of this study suggest that the Rastelli type anatomic repair is probably superior to the other surgical approaches in terms of the in-hospital mortality. But still, it didn't answer the question why the patient subgroups may benefit from one surgical approach or another. They looked into that one. They found that there was 69 patients who underwent anatomic repair, the Rastelli type. They had 25 patients who underwent the anatomic repair with the arterial switch, and the 30 patients underwent physiological repair. They had 13 mortalities out of this 124 patients. They compared the different groups. They found that 7 out of the 30 in the physiological group have died. And they have found that in the Rastelli, they have only 3 patients out of the 25, which is 4%. And they had, of 3 out of the 69, which is 3%. And they have 3 patients who died in the group from the arterial switch, which is 12%. The explanation that they said that maybe the Rastelli type has got a technical advantage. When you do the ventriculotomy, you can directly visualize the VSD and you can avoid the conduction tissue, so that minimizes the heart block issues and the conduction problems after. Also, when we are doing a ventriculotomy, you can also address the tricuspid valve at the same time. Compared to the coronary, the arterial switch to the Rastelli, there is no coronary transfer, which also minimizes the chances of having ischemic problems from the translocation of the coronary arteries. I haven't included the tables for that, or the putting the surgical, the surgical schemes about the surgical repair that we do. However, this, like as a conclusion of these 2 papers that I have reviewed, I think the congenitally corrected TGA is a heterogeneous population of the patient and wide anatomical variation. They are a very rare type of congenital anomaly, and that has affected the number of studies. So there are no big cohorts of patients. Only one meta-analysis that I have found. The group of the patients are variable. The studies also are variable in sizes. So there are some presentation of 2 cases, and the maximum I've seen was about like 29 patients. The thing is, arterials, atrial switches, some of them, like the old studies in the 70s, they were talking about the physiological repair only. And that's the 70s, 80s when they started. And reaching now to the last decade, most of the studies are addressing Rastelli and atrial switch, or arterial switch and atrial switch. So there is no single approaches available which represent a satisfactory medical or surgical solution to all the cases. The determinants for the post-operative morbidity and mortality are multifactorial and complex. So we cannot tell why this approach is better than the other one, or why are the results of this are better than the others. Not plenty of cases being done, and also on the same thing, the variability of the patients themselves. Physiological repairs are associated with significant morbidity and mortality, and the long-term outcomes with the systemic RV are unfavorable. The last one is going to be as I said, the anatomic repairs have better short and medium-term outcomes, but there is late incidence of reoperation. There is a late incidence of reoperation, ventricular dysfunction, transplant, and death. As a general statement, it's just like a rare condition, low numbers, limited studies. So I think it's open up for different inputs from different expertise. Every center, every surgeon who's got like an experience in treating this type of conditions can also vary his decision according to the individual patients at the time of the surgery. And that's it. Thank you.
Thank you, Ahmed. Really sorry for this short notice. I had this short notice from the supposed speaker as well. So thank you very much for help and giving the hand. So I think it's the most controversial topic in congenital cardiac surgery, because we have to decide should we do anything and when we should do and what we should do with patients. They're usually doing well, and we have to do massive surgery for them, and with, I mean, sometimes not really good results. So next week, Shri will cover surgical options for these patients widely in full presentation. And I have asked Mr. Danaponeni to present his data as well about our experience. He's reviewing data at the moment, and he kindly agreed to present this probably next time or on one of the sessions regarding our results and our decay. So any questions to the Ahmed or any comments from the auditory, please?
I think just like the as you said, it's a complex condition, and there's not plenty of cases in there. We have done one just like the day before yesterday, which was the Ahmed and the Rastelli. The thing is that clarifies this boy was 2 years 10 months old, and the timing of the surgery at this age was helped by him having that PS, which is one of the main things. But the other group of patients who do not have this type of either a VSD or a PS, they need to be addressed early, as in the neonatal stage, same as we do with our arterial switch. Whether this impacts us, I think it's because it's a more complicated surgery than the arterial switch on its own when you do both the arterial and the atrial switch. So I think this is one of the good groups when they are presenting with the VSD and PS.
Hi, Ahmed. Thank you for
Hello?
the presentation. That was great. Can you hear me?
It wasn't that good, but thanks for the compliment.
Well, it's a good overview for a condition we don't often see. My question really is perhaps more for cardiologists than for the surgical team. Clearly, in the very simple ccTGAs with no associated abnormalities, they can go, I suppose, unnoticed with very little features to be picked up clinically. How good are these? And if early treatment is like the TGAs, early treatment produces best results, then how good is antenatal screening in picking up ccTGA?
Nayan, is Ram here?
Ram, yeah, go ahead.
Can you hear me? Yeah, so I mean, from the antenatal point of view, the presentations for ccTGAs, we can pick up based on the newer guidelines. You know, like recently they have included the parallel views for the outflow tract, because on the 4-chamber, if they carefully look at it, they can pick it up. The other ways of presentation is they can present with heart blocks with a very bradycardic presentation. And so they have a fetal guidelines to look for. If the heart rate is less than 120, 110 persistently for unexplained maternal reason, they will refer those patients to fetal medicine unit. So when we diagnosed antenatally, I mean, the things we look for is mainly, heart block and any functional compromise, like in the absence of associated anatomical structural association, because often you see VSD or pulmonary valve problems or subpulmonary valve problems in this association. So if they don't develop any, I mean, we have a few patients, picked up antenatally with the uneven full antenatal course and the normal heart rhythm. So they will be followed up and monitored in the clinic with, I mean, mainly, ECGs and they may monitor the heart function. Then as it comes to the management, as the paper presents, I think it's all individualized case. I think Ram might have a surgeon have better views, because we for an elective, in otherwise well patient who is needing an elective, double switch, it has its own complexity. So I think we individualize based on the family's counseling as well as the patient need. But whoever have got a VST with the previous intervention or VST with pulmonary stenosis, I think we are more in favor of doing them into Rastelli type of switch, atrial switch and Rastelli, like the patient who had this week. But the completely normal anatomical structure ones, I think, I don't know, Ram, you were there, correct me if I'm wrong. Previous Birmingham unit, the guidelines, they say investigate them, between 5 and 8 years of age and start, if they are keen for double switch, and start doing the LV training and other things. But many patients, they don't go on that route.
Yeah, great. Thanks.
Thanks, Ahmed. Thank you very much for filling in with a very short notice. I think it was less than 24 hour notice, but you managed to pull something. And it's good that you kept going this discussion, which already started since last week. My personal view, with ccTGA is that, as we said, it's very rare. And there's a lot of variability in this as well, because ccTGA comes with dextrocardia, mesocardia, situs inversus, and all. So everything is so complex. So my view is that if a ccTGA has got no associated lesions, in the sense no VSTs, no PS, then probably it's better not to touch them, because they can live into late 30 or late 30s or 40s without any problems before getting into trouble with systemic RV dysfunction or tricuspid regurgitation. But if you try and ban them and do the surgery, then they have mortality, they have risk of mobility and reoperations in terms of baffle leaks, baffle obstructions, and so on. So my personal view is, why touch them when they are asymptomatic, they have good hearts, functioning hearts, they can live up to 30, 40 years, and they go on transplant in a better condition rather than operate on them. But if you have associated lesions, then you're forced to do something. If you have a VST or a pulmonary stenosis or subpulmonary stenosis, you have to do something. If it is a VST, it's straightforward. The initial stage is to PA ban and then repair later. If it is a pulmonary stenosis, you can wait as long as the pulmonary blood flow is good. If it is a pulmonary atresia, you might need to do a staged operations like Carson had, like a shunt and etc. In terms of what Ahmed touched about physiological repair or anatomical repair, yes, you could do a physiological repair just by simply closing the VST. It probably is acceptable in some centers or some countries where you don't have the facilities for a full double switch or Rastelli sending type of programs. That's completely acceptable. But in countries like UK, Europe, US, we are forced to send to somewhere else where they can do it rather than do a physiological repair by simply closing the VST. That is inadequate in this setting. But if you can do that, probably anatomical repair is good. But that's my opinion. It's a very rare condition. As we said, not much experience to definitely say which one is good, which one is not good. Thank you.
I've got just another comment, which is we have mentioned the trial of picking these patients on the fetal screening or like an antenatal screening. The problem is if these are not picked up in the fetal screening, they are missed because of those, especially with the congenital corrected TGA not associated with other intracardiac problems. They usually go on and they can, as Ram said, they can go on and they can live their normal life till the 30s and 40s because they are clinically or they are physiologically normal. However, if they are those type of patients that we can either pick on when they are in the baby screening and when they like the postnatal screening. I mean, even as a pediatrician, when they do the first check for the babies at the 1 week old and 6 weeks old, if you find that they have got a murmur either as a PS or a VSD, then this can direct or can initiate another cardiological more in-depth investigations. And then this group of patients, which actually more that we are operating on now, they are mostly picked because they have been symptomatic, either because of congestive heart failure coming from their VSD, or because sometimes if they have passed that time and they are having a more of a right to left shunt, and they start to be cyanotic. And this is another type of presentation. Most of these type of patients, they are coming and presenting in not in the neonatal stage, they are at a later stage. With the presence of VSD and the PS, that gives us the advantage of having more stage repair, as in having like shunts, Glenn as the other patient that we have done the day before, and then going on for the ultimate or the total corrective surgery when it's more appropriate for them. I think because of that's why we are facing most of the patients as this or the one we operate are within this children or the in the infant rather than in the neonatal category. And probably we can do some sort of writing of our patients that we have done. I think the market for this presentation is quite wide because there is no much in it, and we can provide our point of view from Alder Hey Center. Thanks.
Should we conclude as well? Thanks, sir. That's not much.
Okay. Any other questions or comments? So thank you for everybody very much for participating. And next week we will have our teaching during the Quacky meeting first thing in the morning. It will be Wednesday. So please, we will announce in what channel we will do, probably in Quacky channel. Yeah, but we will say it later. Thank you so much.
Oleg.
Have a good day.
Oleg.
Yeah.
Oleg.
Yeah, can hear you.
Hi, sorry, just to mention that actually that usually this teaching starting at 9, because we have Kaki next Wednesday, it's gonna start at 8:30. So it will be circulated in the agenda and widely. So, but the teaching will be from 8:30, and then we start the Kaki. And then we have at midday, we have the webinar with the Toronto Sick Kids. So it's going to be a busy day. Yeah.
Thank you. So have a good day. Bye-bye.
Thank you.
Thank you, Oleg. Bye. Thanks.